With that, we're going to start with the lecture 501 or 0501. And do you all have that up on your screens? Okay, good. In the handout book, you'll notice that there's actually a couple of page of notes there with lots of good terminology to be familiar with. Some of this should be reviewed from the terms that you actually studied at the very beginning. But it is important to understand these words and to really have a good sense of not only what they mean, but what they look like on histology and cytology. And that's really going to be our focus today. All right, some terms, as I mentioned, these are some of the terms that are most common. There's some others that are in the handout there that we'll go through as we go through the lecture. Hyperkeratosis, sometimes abbreviated as HK, parakeratosis or PK, squamous metaplasia, both immature and mature, hyperplasia, hypertrophy, atrophy, and of course reserve cell hyperplasia. And we're going to look at most of these. Here's some others. There's actually a pseudo PK, meaning it resembles PK, but it's not. Now we'll talk about that later. Acanthosis, which is thickening of the epithelium. Microglandular hyperplasia, sometimes referred to as MGH. Endocervical polyp. Ectropions, eversions, erosions, ectopy that can occur on the external cervix. And some of these are clinical, primarily clinical terms, like ectropion. And then, of course, vaginal adenosis. So, again, in general, both cervical squamous and glandular epithelia respond to stimuli in a variety of ways. Hormonal deficiency states, external stimuli, including physical trauma, infection, inflammation, etc., can play a role in causing changes in the epithelium. And the processes may be protective, reparative, regenerative, destructive, or neoplastic. You remember the general cellular activities, right? What are the 4 general cellular activities? There's 4 of them that are just basic cell activities. One is euplasia. What are the others? Anyone remember? That was a couple modules ago. I know it seems like forever ago, right? So euplasia, proplasia, does this ring a bell? Neoplasia, dysplasia, does it ring a bell? No, I am almost certain that you've heard these terms before, but I could be wrong, and I will take your word for it. So, all right, so the general idea in mind with a normal cell is euplastic. It shows normal activity in the nucleus, okay? A cell that's undergoing a response to something and it shows benign, responsive, and protective changes is most often going to show evidence of proplasia, okay? Whereas a cell that's responding to something that's going to cause it to be abnormal, the first step is dysplasia, and then when it becomes malignant, then we're talking about neoplasia. So those are some, and there's also retroplasia I forgot to mention, which actually refers to some degenerative changes. So you'll get a feeling for these general terms as we go along. But today, our focus is really on euplasia and proplastic changes, reactive, regenerative changes. Now again, even these changes can cause some atypia, which refers to a departure from normal. But atypia here doesn't necessarily mean it's an atypia associated with dysplasia or malignancy. It's just some kind of abnormality to the nucleus. So today, really what we're focusing on in this lecture right now is HK, PK, reserve cell hyperplasia, and squamous metaplasia, both immature and mature. And our focus right now with this lecture is actually primarily on the histology, pathology, the histopathology, which we sometimes combine together. And the next lecture, and we may look at a couple of cytoimages in this lecture, but the next lecture will focus on these same things, but focusing on the cytology. As you know, we always got to look at the histo first before we look at the cyto. So here's a section of cervical tissue right from the transformation zone. And remember, this mature squamous epithelium up here represents the ectocervix, right? Okay. Here's the endocervix here, and you know there's a kind of a gradual transition oftentimes between the endocervix and the ectocervix. Patients who've been exposed to some external stimuli are more often to get this transition, this larger transitional area between the squamous and the glandular epithelium. And the cell type that is seen most common in these areas of transition is the immature squamous metaplastic cells. And that's what we're seeing here. Okay, you've got your mature squamous cells here that have abundant cytoplasm, paleness to some of the cytoplasm because of glycogen that gets washed out, and has a nice orderly arrangement with the smaller, darker basal nuclei at the lower layer and the most mature cells at the surface layer. And of course, you've got your endocervical glandular cells that are columnar, usually a single layer of columnar cells with basally located oval-shaped nuclei, and then mucinous material in the cytoplasm. But then in between, you kind of have this, again, as part of this transitional zone, you have immature, what this arrow is pointing to is immature squamous metaplastic cells. And really what this represents is endocervical cells that have undergone metaplasia in response to some kind of external stimulus, and they're starting to become squamous. Okay, they're undergoing metaplasia from glandular to squamous type cells. Because what does that do? Remember, squamous cells are protective cells, correct? And so the more squamous features you see in cells, it allows it to be protective against some kind of external stimulus. So, and you notice here, you notice how these are squamous cells, but they look darker. They don't have as much cytoplasm. And the reason they look darker on histology is because their NC ratios are higher. They're smaller cells than mature squamous cells, okay? So that's why they look a little darker here, but they're normal. They're normal as far as comparison to dysplastic or malignant cells. They are not dysplastic, they are not malignant, okay? It's a response to some kind of stimulus. And there's other different types of changes that can occur in the epithelium. First, we're going to focus a little bit on the reactions of the squamous epithelium. Again, going back to this picture here, we're going to be focusing on what happens to the mature squamous epithelium and how it can respond to benign proliferations, okay? And the key terms here are acanthosis, hyperplasia, hypertrophy, hyperkeratosis, PK, and of course atrophy, which actually means thinning of the epithelium. Now, acanthosis is a protective phenomenon, and basically it means thickening of the squamous epithelium. So instead of the normal 7 to 8 cell layers that we may see in the squamous epithelium, there'll be more than that, because the thicker it is, the more protection it confers. And again, this may be reactive, and most often is, especially when there's nothing else going on with those cells. Because acanthosis can be a component of other changes, including even HPV effect, which is a type of infection that will cause disease. So acanthosis by itself, with squamous cells that look normal, with normal nuclear features, is a benign response. And it's protective. Here's an example of squamous epithelium. It actually has some keratin on the surface as well. So in addition to the epithelial layers that look kind of irregularly thickened here, you see how I can count many more than 7 to 8 cell layers thick here, okay? So that's what it's referring to, is the number of cell layers here have gotten thickened to make the epithelium overall look thicker. Okay, but it also, this particular case is also showing some hyperkeratosis. Remember what squamous epithelium of the ectocervix normally looks like? It doesn't usually have a keratin layer, right? Okay, and so when you start to see that, that's actually a form of hyperkeratosis, which is also a protective reaction. And speaking of which, okay, hyperkeratosis is often preceded by acanthosis, and they're often seen together, okay, on histology. And now keep in mind, when the epithelial layer is thickened, are you really going to see that on cytology? No, you can't, because all you see is normal-looking squamous cells. So you can't really make a call of acanthosis on cytology. It's actually a finding only seen on histology because of the tissue arrangements. But hyperkeratosis you can appreciate on cytology, as you'll learn later today. And like I said, they're often seen together, a thickened epithelium of acanthosis, a layer of keratin on the surface, that looks similar to skin. And sometimes actually you'll see PK in there as well. They're often all three seen together. But what does it look like clinically? When the gynecologist looks at the cervix, what does he see as indicative of hyperkeratosis? It actually looks like leukoplakia. You know what that means, right? White, yes, exactly. White-colored tissue, basically. White mucosa, white-colored mucosal patches. That's what hyperkeratosis tends to look like grossly. And it can be seen in a number of conditions that cause benign proliferative reactions, such as uterine prolapse. Does everyone know what that means? It's when the uterus, the ligaments get loose, and the uterus kind of falls down into the vagina, and it can get so bad where actually the cervical os is seen right at the introitus of the vagina, the external opening. So that's due to the ligaments getting looser. And what happens with that is that the cervix doesn't have its normal mucinous protective environment of the vagina, and the epithelium that's on the surface gets irritated, okay? And irritated, because it can undergo inflammation and then undergo some of these changes that are protective to help protect the epithelium. All right, so, and all the other underlying tissues that the epithelium protects. It's also related to underlying inflammation, chemical trauma, physical trauma, chemical trauma as in sometimes some of the compounds that they use to treat certain lesions of the cervix can cause irritation and inflammation. And like I said, it's often present with parakeratosis. They're often seen together. And here's a picture of both HK and acanthosis. Again, notice how the squamous, some of these pictures are taken from the Robbins Atlas, the more current edition from 2009. I don't know if you actually have that here. You have one? Okay. Robbins is a really great book for histopathology. It's actually a general text for pathologists, but it's our Bible for general pathology. And in fact, it's the book that I learned pathology from when I was in medical school, okay, which was actually a very long time ago. Now, I actually last year celebrated my 25th anniversary from graduating from medical school. So the Robbins edition that was used back then was like, oh my gosh, I think it was like the second edition. So he's up to the 8th now. But I know I feel old all of a sudden. But it's a great book, and it's actually a book that's used throughout the medical schools, and also in our residency programs. But and there's a copy here, and we're going to share some of these images with you when we do the histology. And so this is one here, and indeed you've got thickened squamous epithelium. You've got this you see the keratohyalin granules in the superficial squamous cells, which you don't normally see in normal ectocervix. But that is a response to this, proliferative reaction as well. And then, of course, you've got this very thick keratin layer. It actually looks like skin, all right? And in fact, it probably is. This is actually probably because you see dermis here, that's actually refers to skin. But this is what actually happens in the cervix when it undergoes thickening and hyperkeratosis. It actually resembles epidermis, which allows additional protection. Okay, here we go. Okay, actually here's a picture of uterine prolapse, and indeed there's different stages of it. Again, in relation to the other organs in the pelvis, this is the bladder. Here's the pubic bone right here, the bladder, the uterus, the vagina, and then the rectum right here, and then the spinal column over here. And so here's an ovary and a tube. And so this is normal orientation. In prolapse, you can get different forms of uterine descent, as they call it, and some of them will show the anterior wall, some will impact on the anterior wall, some will impact on the posterior wall. So what's happening here is the bladder and the urethra are actually pressing against the vagina, whereas here the rectum is actually pressing against the vagina. And here you get central prolapse, as I described earlier, where a portion of the uterus goes into the vaginal canal, and it can actually go all the way down to the introitus in some severe cases. All right, what about PK? Look, again, it's a protective reaction. It represents hyperdifferentiation of the squamous epithelium. You can make it out pretty well, and it's often combined with hyperkeratosis, usually overlying mature squamous epithelium. Occasionally we'll see it over metaplastic epithelium, which is more of an immature squamous epithelium. It's benign, but the important thing to remember is it may overlie a more serious process underneath. Occasionally we'll get pap tests on patients and all we see is PK, and then they undergo a biopsy and underlying, lo and behold, there's a dysplasia there that was not seen on the pap test. That happens sometimes. It's a sampling issue. It's not that it was missed on the pap smear, but it's just sometimes the PK will mask it. We don't report out PK in our reports. We used to many years ago, actually, about 15 years ago. We used to report PK as a finding on pap smear cytology. We don't do that anymore because it's generally considered a negative, benign negative reaction. It's important to recognize, though, because it can sometimes be a clue to look for other abnormalities. If you see a lot of it, it kind of raises a red flag and say, okay, I got to make sure that they're not atypical and that there aren't other atypical cells present. So it's kind of like a warning flag. But if all you have is typical PK, it falls into the NILM category on pap test reporting, as you'll learn later. Here's an example. Again, notice the epithelium here looks acanthotic. It's thickened. There is a little bit of granular layer on the surface here. There's some hyperkeratosis with keratin present on the surface. But in addition, unlike the other cases of hyperkeratosis I showed you, you see there's actually tiny little nuclei here. That's when the keratin layer on the surface shows the presence of nuclei, that indicates parakeratosis. Okay? When there's no nuclei, it's just hyperkeratosis. You understand that difference? Okay. What about atrophy? As I told you, atrophy can be seen, especially in women who are postmenopausal and have reduced estrogen. Women who are postmenopausal and on estrogen therapy, which is not uncommon, should not have the same response because the estrogen will help keep the squamous epithelium mature. And what happens with atrophy is you get thinning of the epithelium, so now we're talking the opposite of acanthosis, and decreased maturation of the squamous cells that results in the thinning of the epithelium. And this is primarily due to estrogen deficiencies, okay? Estrogen is really important to the overall maturation of the epithelium. Here's an example of one showing you a patient. This is premenopause, this is postmenopause, and this is dividing the squamous layers into superficial, intermediate, and parabasals. And what you see here, if you remember from your maturation, you got exposed to the maturation indexes in hormonal cytology, right? Well, this is and you looked at what an atrophic smear looked like. So this is just showing you what it looks like on histology. You've got the parabasal and basal cells are down at the base, usually only 1 or 2 layers. Intermediate cells are your thicker layer of cells, and then you've got this thin layer of very mature superficial cells on the surface, which comprise about 15% of the epithelium normally. Postmenopausally, this mature layer gets thinner, as does the intermediate cell layer, and the parabasal cells tend to proliferate. And again, this is indicative of the immaturity of the epithelium. Again, here's a good example of that. Here's the normal, this is from the vagina now, but remember the vagina is also squamous epithelium, and it's going to show you some of the same responses as a cervical squamous epithelium. And it also responds to estrogen. This is interesting histology slide because it actually is, there's a special stain here that's highlighting some of the nuclei. You see the brown? Okay, that's actually an immunostain. But I just wanted to point that out. You don't need to know that right now, but it's a normal epithelium, and it's showing you normal maturation of the epithelium with a very small basal, parabasal layer with lots of maturing intermediate cells, and then a thinner layer of superficial cells at the surface. In contrast, this is an atrophic vaginal squamous epithelium, and the cells look very different. They look very immature. There's a bit more crowding here. Despite their immaturity, though, the nuclei look very uniform throughout, and that's important in distinguishing it from something dysplastic, because dysplastic epithelium can, at low power on histology, can have a similar appearance. But these cells look, although they're immature and show higher NC ratio with less cytoplasm, which is indicative of their immaturity, they're still normal, okay? And it's a normal response, sometimes seen in atrophy. Here's another example of atrophy. We're not seeing the surface epithelium here, but probably think of it as being up here. And what it's really showing here is, again, some very immature squamous cells, a little bit of nuclear enlargement, but not to the point of being abnormal. And then less evidence of squamous maturation and causing thinning of the epithelium. So there's not as much protection afforded with these atrophic epitheliums. And they can undergo a lot of irritation and inflammation because of that. And it'll explain often why some atrophic epitheliums often have a lot of inflammation, and we see commonly atrophic vaginitis because of that. Estrogen is the treatment primarily. Estrogen therapy, either topical or oral estrogen compounds. All right, now we've been talking about squamous epithelium. What about glandular epithelium? It's there too, and it can also undergo some responses. One of the more common ones is reserve cell hyperplasia. Remember, it's the reserve cells that are the progenitor cell for the endocervical glandular cells. And they can undergo hyperplasia as they're also responding to something and trying to make new endocervical glandular cells. Squamous metaplasia is, as I mentioned, is a response of the endocervical cells where they undergo metaplasia or transformation to the more protective type squamous cells, and there's both immature and mature forms. Now, pseudo-PK, we talk about PK, but pseudo-PK primarily affects the glandular cells. And what it represents are glandular cells that have undergone degeneration, and because of a response to something, inflammatory, infectious, etc. And what happens to cells when they get degenerated on cytology? What do they start to look like? What color? You remember the normal endocervical cells are either cyanophilic or lightly basophilic in color. But what happens when they get degenerated? They look eosinophilic, right? And they can actually also shrink in size, and they don't look columnar. They start to look rounded up. And so they actually start to resemble cells that look like PK cells, and that's where the designation pseudo-PK comes from. And we'll look at some pictures later on. Also, endocervical polyps are just polypoid proliferations of the endocervical tissue lined by normal endocervical epithelium. We'll look at that, as well as microglandular hyperplasia, something we see not uncommonly. And in fact, it's actually found in women who are on, commonly in women who are on oral contraceptives. And it really is a very nonspecific finding, but it's just a benign response of the endocervical glands, and we'll look at some examples. All right, first of all, reserve cell hyperplasia. Reserve cell hyperplasia, again, are your undifferentiated cells just above the basement membrane, but below the glandular columnar cells. we don't see, they don't stand out very well like the basal and parabasal cells do on histology or cytology for that matter. But they're there. Okay, you know that those are the cells that are giving rise to the endocervical cells. It's just that they're not often seen. They're not very commonly seen. And in fact, when we see them on histology and cytology at all, to me, that's an indication that we're probably dealing with reserve cell hyperplasia when we actually can see a lot of them. So sometimes this entity is referred to as basal cell hyperplasia, but it's in the endocervical epithelium. That's not really a histologically correct term. They're really formally referred to as reserve cells. Now, if any squamous differentiation is present, it's really not reserve cell hyperplasia. In that case, it's actually immature squamous metaplasia, and we'll talk about that too. All right, in its earliest form, reserve cells form a single layer of subcolumnar small cells, usually one but not more than 5 cell layers thick, but occasionally they can get quite thick, up to 12 layers, and can resemble small basaloid cells, is probably the better word. There's no cell borders. Generally, it's at the transformation zone, just like squamous metaplasia is, and tends to be more proximal in the endocervical canal at the transformation zone. So in other words, it's higher up in the endocervical canal. When I say more proximal, it means higher up in the canal than squamous metaplasia. And to be honest, often reserve cells and squamous metaplasia are seen at this together, okay, all right? And I'll show some pictures of that. Now here's an example. Again, oftentimes you'll see at the surface the normal endocervical glandular cells kind of hanging out along the surface. And underneath you see these small but bland, round to oval cells that generally are about the same size as the endocervical cell nuclei, okay? But they have less cytoplasm. They have higher NC ratios, okay? The nuclei remain bland, so there's nothing, usually atypical or neoplastic concerning for these cells. It's just you have to get used to the fact that they do have high NC ratio and they do look very immature. And you don't want to mistake them or overcall them as something abnormal, which you'll learn in the next module. All right, here's another example, and then you'll understand sometimes they can get a little reactive in appearance, and their nuclei, when they get reactive, can start to show some more nuclear enlargement, some nucleoli. They start to look reparative, and we'll talk about repair as we go into the next lectures. But you can understand why this epithelium is showing this response. Look at all this inflammation here. These are neutrophils in here. Normally you don't see a lot of neutrophils in the cervical epithelium, okay? So there's some reason why the neutrophils were there, some underlying infection, irritation, etc. So you got all these neutrophils here, so the endocervical tissue is and there's also lymphocytes too, by the way. Okay, so here's the basement membrane. This is the underlying connective tissue. You've got lymphocytes, you've got a small capillary here with some blood cells within it. You do have some scattered neutrophils not only in this underlying stroma, but also intraepithelial. Here's your overlying endocervical glandular cells with their normal appearance. You've got a nice columnar shape with a basally located oval nucleus. It looks a little bit degenerated here because, the chromatin's kind of dark because of that. You got a little bit of mucin on the surface because remember that's what it's forming. And then just beneath this single layer of columnar cells are these cells here that look very immature, can't make out any cytoplasm borders. They're high NC ratios. But, despite, and a little bit of nuclear enlargement compared to the endocervical nuclei, and these are reserve cells. This whole layer here is an example of reserve cells undergoing hyperplasia in response to some kind of stimulus. All right, here's another example. Now this is on cytology, and it's showing you a nice little aggregate of the normal endocervical glandular cells here. And right beneath, you'll see this smaller, darker cell here and here. Those are, and this one too, those are the reserve cells. Very small, very high NC ratios. We don't really see many of them on cytology. When you see them, you're like, ooh, we got to make sure they're not something other than that. But it's important to be able to recognize them so you understand what they are and not mistake them for something else. All right, reserve cell hyperplasia is more common in pregnancy and later in adult life, especially when epithelium starts to become atrophic. It's important because cytologically the cells can resemble something abnormal like carcinoma in situ. Okay. And you'll learn those differences when we go through this in module 6 and 7 actually. The nuclei, though, despite the fact that they're small with little cytoplasm, they're round, oval, or reniform, and may have occasional grooves. The normal nucleus will show fine, uniformly dispersed chromatin, small chromocenters. Unless they've undergone a little bit of reactive changes, they may have prominent nucleoli. Okay, but they do not have features of dysplasia, and that's important that you are able to distinguish them. Eventually you will be able to distinguish them from dysplasia. Here's an example of a pap test that has a lot of eosinophilic color to it, but nevertheless these are superficial cells here and here and here, and then you've got some neutrophils in the background that are just along for the ride. They're kind of nonspecific here, but this is the group of reserve cells right here, and you can see again, very high NC ratio, little cytoplasm that tends, in this smear, is staining eosinophilic like everything else, and the nuclei are round to oval, uniform chromatin, and indistinct nucleoli. All right, next we're going to go on to squamous metaplasia, which is a very common response in the cervix. So common, and again, it provides protection to the epithelium, and it is so common that we really don't. It's not considered an abnormality in cytology, but it is important to recognize it, as you'll learn, that it represents sampling of the transformation zone. So we know that we're getting a good pap smear or pap test to review. It is the most common protective mechanism. It may be preceded by reserve cell hyperplasia, and sometimes there's a transition between the two. And it can be, it can sometimes be difficult to separate out reserve cells from metaplastic cells, but you're going to learn to do that in this module, okay? And I think, and I'll show, you'll see the differences when I show you the images in momentarily. Again, metaplasia can respond to any, as a protection to any type of external stimulus, to include chronic irritation, inflammation, response to chemical agent, pH changes in the cervix, okay, and other stimuli. Again, it's most commonly seen at the transformation zone, which makes sense when you're dealing with your transition between endocervical and squamous epithelium. It is benign, and you have to be wary that dysplasias may arise in metaplastic epithelium, because most dysplasias occur at the transformation zone. So it's important to understand, to have a good feeling about metaplasia before you start learning about dysplasias. All right, so this is actually now I told you that squamous metaplasia can either be mature or immature. And basically, mature squamous metaplasia resembles normal squamous epithelium, okay? Really. The only way I know that this is actually an area of metaplasia in this cervix is the underlying endocervical glands. Because remember what normal ectocervix looks like. It doesn't show endocervical glands in the stroma. That's where I know I'm at the transformation zone here, when I start to see endocervical glands, either on the surface or in the stroma. So these are normal endocervical glands down here. They at one time connected to the surface up here, and at one time this surface epithelium was endocervical glandular epithelium, but in response to some kind of stimulus, it underwent transformation to mature squamous epithelium. And here it looks very mature. And I dare say, if you got a cytology sample of this type of epithelium here in its most mature state, you couldn't tell it apart from the other normal mature squamous cells on the smear. But the key with this understanding metaplasia is that there's a gradation of changes. It starts out very immature and then becomes more and more mature. And when they're in that change like that, they do look different than the mature squamous cells. So that's what you need to learn about. Immature is sometimes called incomplete squamous metaplasia. And again, these are the earliest forms of squamous metaplasia of the glandular cells to this metaplastic state. The cells definitely look more immature. And the epithelium of immature, the histology, actually, these epithelium tend to be quite thin. You don't see intercellular bridges as you would in mature squamous cells. They may have overlying columnar endocervical cells too, and I'll show you a picture of that. And again, there's oftentimes what we call the tweener or in-between cells that some may show glandular and kind of a combination of both glandular and squamous features. Because remember, nothing is really abrupt, right? You're learning that, aren't you? Okay. That there's always kind of this transition between the cells. All right, so here's an example of immature squamous metaplasia. Unlike mature squamous epithelium, first of all, you do have a layer of endocervical glandular cells on the surface that look like relatively normal endocervical cells. And just beneath it is this layer of cells that are starting to look squamous. Now again, you notice down at the very bottom here, they kind of resemble the reserve cells I just showed you, don't they? Okay? But the ones up here have more cytoplasm and more of a amorphous appearance, density to the cytoplasm that actually resembles squamous cells, but not quite mature squamous cells. Okay, so these are immature squamous, and again, the epithelium tends to be thinner than a mature squamous epithelium. Again, another example here. Now here you can still see cell borders and intercellular bridges here. You can't here. So what's happening, you've got the most immature cells down here and the more mature squamous metaplastic cells up here, but they're still less mature than the normal squamous epithelium. So again, it's kind of like this gradation of maturity. And what do they look like on cytology? Again, we're going to look at more of this in the next lecture, but just as a little introduction here, you've got your mature squamous cells in the background here. Looks like a superficial here. This reminds me of the nucleus reminds me of a superficial nucleus because of its size. And then you've got these cells here, and here are normal glandular cells. Right here, you got some neutrophils. But these are the squamous metaplastic cells right here. And you notice how they kind of aggregate together in these loose groups. You can actually make out cell borders here. You notice how they still retain a polygonal shape like the mature squamous cells, but the key difference is here is that they have less cytoplasm, they have higher NC ratios, the nuclei are larger. In fact, sometimes the nuclei, the nuclear size can be anywhere from that of a normal endocervical nucleus up to one that's 1.5 to 2 times bigger than a normal endocervical nucleus, but they do show some variations in nuclear size, and we'll talk about that in the next lecture in a little bit more detail. But I just wanted to show you an example of immature squamous metaplastic cells. Here's some more. Again, notice how they're smaller than mature squamous cell, obviously, higher NC ratio, slightly larger nuclei than an intermediate squamous cell, a little denser cytoplasm. They tend to have more of a rounder shape than classic polygonal, but as you saw in the previous one, some of them did look polygonal, right? They can. Okay, now again, what I want to re-emphasize about mature squamous metaplasia is it morphologically resembles the native squamous epithelium. And so in other words, you're still going to see some immaturity to the cells, they're not completely mature, okay, but just remember that when it's in its most mature state, it looks just like normal squamous cells. The clue is on histology. When I mentioned earlier, you see glandular spaces underneath. And if they're fully mature, it resembles a normal squamous epithelium with a basal, parabasal, intermediate, and superficial layers, just like normal. And we see mature squamous metaplasia in at least 50% of cervix that we see on histology. It is not an abnormal finding for us. Like if I see it on histology, oh, okay, she's got some squamous metaplasia, no problem. That's normal. I don't call it anything abnormal, okay? I don't, unless for some reason there's some dysplasia associated with it, and then I might mention it. But it's totally normal. And it's a protective mechanism that results from chronic environmental stimuli, local or hormonal, which is very common in women. Here's another example of mature squamous metaplasia, just highlighting that there's normal squamous epithelium on the surface. You would generally see some endocervical glands in the stroma here as well. That would be a clue to squamous metaplasia. Now, here is almost fully mature squamous metaplasia, because remember, some of them don't quite look like normal mature squamous cells, do they? Okay. But in contrast to immature squamous metaplasia, they do have more cytoplasm. The nuclei are actually starting to look a little bit smaller in size, and starting to get to the size that they more likely resemble that of either an endocervical cell, or even up to the size of down to the size of an intermediate squamous cell. But these nuclei are still slightly larger than intermediate squamous cells. They still have a higher NC ratio compared to normal squamous cells. These are all these cells right here. But they're starting to look much more mature. Their epithelium is looking more squamoid. It looks like it has more density to it. Some of them are looking polygonal rather than round. Okay, so you're going to see both round and polygonal shapes. So the more cytoplasm they have, the more evidence of keratinization as a nuclei, and the NC ratio starts to get lower. That indicates more maturity to these cells. All right. Okay, so now is everyone clear on that?
Okay. Are you have to be able to distinguish mature squamous metaplasia from just regular vaginal epithelium on a cytology?
I don't. Do they have to distinguish mature squamous metaplasia from normal squamous cells?
Oh, yes. Awesome.
But, I understand why we're doing that, but you have to remember that the most mature squamous metaplasia cell is going to look like a normal squamous cell. But the reason we make this distinction, as does the textbooks, is that when we're referring to mature squamous metaplasia, it's really not quite fully mature. You see the difference? Okay, so when you see the term mature squamous metaplasia as opposed to immature squamous metaplasia, it means that it's more mature than the immature, but it's not quite resembling a normal squamous cell. So in other words, you've got your immature squamous, you got your very immature squamous metaplastic cells, you've got your almost fully mature squamous metaplastic cells, and then you've got your totally mature squamous metaplastic cells, which in my book resembles totally normal squamous cells. So
mature squamous metaplasia just means almost complete.
That's right. Does that help explain? I don't want to confuse it, because the terminology is a little bit confusing.
The rationale is to, when we start screening, there is a sign that you have sampled the transformation zone. We'll talk about that later.
Yes.
You actually have to be able to differentiate, I know for training purposes, you probably have to differentiate immature as opposed to mature squamous metaplasia. No? Or would you just call squamous metaplasia?
So there you go. So you see, it helps. You don't have to make, I would find it very difficult in some circumstances to differentiate immature from mature. But it's important to recognize that there are these differences, okay?
Is there some type of pathology or something that one might be more like stick out more than immature, mature might stick out more than one or the other? Would it lead you towards like some type of pathology or something? I know that's like kind of getting out of it.
I'm not sure what you're asking, I guess.
And if you see a lot more mature squamous metaplasia as opposed to immature, is that indicative of something or?
No. All it tells us is that there's squamous metaplasia on the cervix, and it was there as a protective, is some reason, some underlying stimulus.
Unless there is plastic thing.
Well, then the key is that you're,
Well,
no. The key for you right now is just to understand how to recognize squamous metaplastic appearing cells on cytology. And they have different degrees of maturation. You are, and again, and you will be able to distinguish squamous metaplastic. I mean, these squamous metaplastic cells here look different than mature squamous cells, don't they? Normal squamous cells is what I'm talking about. Here you got normal, here you got your squamous metaplastic. This tells you when you get, and again, there's going to be a lot more discussion on this in the future. The sampling of these cells tells you that the transformation zone has been sampled, because remember, that's where squamous metaplasia occurs, at the transformation zone. And that's important because that's where the abnormalities occur, at the transformation zone. So if you don't, and again, you can actually, this tells me we're at the transformation zone, whether or not there's endocervical cells present, you know? I mean, because remember, where do these cells arise from? Where do these cells come from? Endocervical cells that have undergone transformation. So that tells me, again, you know, that we're at the transformation zone. But no, squamous metaplasia cells, whether they occur in the cervix or sometimes in the vagina, as we'll see later on, for other reasons, you know, it's obviously you're not going to be able to tell where those are coming from. They look exactly the same. So whether they're from the cervix or the vagina. All right, pseudo-PK is an entity that occurs in endocervical cells. It represents really a degenerative change is what it represents. And it's often seen in patients with oral contraceptive use. And it's the endocervicals that have undergone degeneration. And it's important to understand this so that you don't mistake them for PKs, because they do resemble parakeratotic cells. And in some cases can resemble significant lesions like high-grade SZCYs or high-grade dysplasias, since the cells tend to be small and round with higher NC ratios. The cells usually occur in streaks of mucin on conventional smears, and the nuclei appear very pycnotic, dark, rather than enlarged and abnormal. And here's an example of one. And again, you notice here it looks like the cells are streaming in one direction or so. And you've got these cells here that have some hints of some vacuoles to their cytoplasm, but they have eosinophilic color to the cytoplasm, which is not typical. Here you see you actually got the nuclei looking eccentrically placed, and that's what endocervical cells have, right? Squamous cells have central nuclei, endocervical cells eccentric nuclei. So when you start to see that with this eosinophilia, that can be a clue to the fact that, oh, maybe they're not squamous cells, they could be endocervical. All right, what about endocervical polyps? These are benign polypoid lesions that occur for a number of reasons, and they cause a papillary or finger-like growth on the cervix that will stand out as a kind of a exophytic growth on the cervix. They're typically lined by endocervical mucosa, and then lining a very vascular stroma. Polyps, whether they're in the endocervix or the endometrium, are often very vascular. And that's how we diagnose them on histology, is by looking for that vascular component in the stroma. But generally it's lined by normal appearing epithelium. In an endocervical case, it'll either be endocervical or endocervical cells that have undergone squamous metaplasia, we can also see on a polyp. They are really not very significant, but they can cause bleeding if they get large. And so generally when a patient shows up for a GYN exam and they see a polyp either in the os or on the external cervix, they're going to biopsy it to keep it from getting larger and causing bleeding. The key for us is making sure there's nothing neoplastic associated with it, because tumors can have a polypoid configuration as well. So we have to make sure that the lining epithelium is normal. Here's an example of one. It's looking at it through the colposcope, and you see the external cervix here, the internal os here, and you can see these little pedunculated finger-like projections of tissue coming from the os. These are typical appearance for endocervical polyp as seen through the speculum. And here it is, if you were to cut the cervix and the vagina, where it's arising from the endocervical canal. They can arise high up in the endocervical canal. They can arise right at the os and any place in between. Here's another. This is from a hysterectomy specimen, and this is actually the external cervix here. It's been opened up to reveal the inner endocervical canal, and there's a little polypoid lesion here, and maybe one here, kind of pale. It's kind of a little bit of a pale picture here, but that's what it's trying to point out. Here's a better one, though, and this is actually showing you from the colposcopic examination. This is actually the vaginal sidewalls. This is the cervix, and you see how the polyp actually has a little bit more reddish color to it. Actually quite a bit more reddish color to it, right? They can be. They can cause some, if they get large enough, they can cause some discomfort, but usually it's not a lot of discomfort. The reason this epithelium looks this reddish is because, remember, here's the external cervix. Squamous epithelium tends to look pale pink. Endocervical epithelium tends to have a deeper pink color to it, kind of almost reddish pink. But the reason the polyp here looks more red, even than I would expect normal endocervical epithelium, is because of its underlying vascularity. Remember, I mentioned there's all these vessels in the stroma, so it tends to look redder. Here's an example on histology, and this is showing you. See, here's the central stroma. They often have some inflammation in here because they can get irritated, and right here are some thick-walled vessels in the stroma, and that's characteristic of polyps in the female genital tract. And then the surface epithelium is just normal endocervical glandular epithelium. If you didn't know, if all you had was this sampled, you'd think that you were just getting a normal biopsy of endocervical tissue. But the key is the thick fibrotic stroma with some scattered vessels, thick-walled vessels. All right. Microglandular hyperplasia, we're getting down to the last couple of things here. Microglandular hyperplasia is basically what its name says, is you get tiny endocervical glands proliferating either near the surface or in the deeper cervical stroma. And these tiny glands are lined by normal, benign endocervical epithelium. They're seen more common in patients who are on oral contraceptives or other exogenous hormones. For instance, postmenopausal women on exogenous hormones. They may be seen but they can also be seen in the absence of hormone therapy. It's a benign proliferation of small crowded glands with this normal endocervical layer. Sometimes the glands will get a little flattened. Instead of having a nice columnar shape, you'll see cuboidal cells instead. And sometimes they can get inflamed, and then you'll see some protective and degenerative changes, including pseudo-PK, reserve cell hyperplasia, and even squamous metaplasia. Often you'll see edema and inflammation in the background, especially when there is inflammation happening. And it's certainly important for us not to confuse the small glands with adenocarcinoma, which we'll learn about later. Now this is an example of one deeper in the stroma of the cervix, and it's showing you these small but benign glands scattered throughout the stroma. And there's just lots of them because you don't normally see this many small glands. So a lot of small glands in a region of the cervix, you don't normally see them, is indicative of this entity. But the epithelium is benign. What about vaginal adenosis? The vagina is normally lined by mature squamous epithelium, right? Well, what happens? There are instances where you can actually get glandular epithelium in the vagina. And when you see glandular epithelium, that refers to adenosis. Now, it can be associated with DES exposure that occurred many years ago in utero. It happens to the daughter who got whose mother received the DES during her pregnancy. So the daughter was exposed to the DES in utero while a fetus. And it shows up years later, okay? Now, they don't use DES anymore, okay? So we hardly ever see this anymore as this being associated with the adenosis, as this being the reason for the adenosis. But it is important that you understand this because it still does occur, and these women are at risk for significant abnormalities that we'll talk about later on in the other modules. But vaginal adenosis can also occur. It's basic for other reasons, and it can be nonspecific. We see it often in older women sometimes with little red patches in their vagina. They sometimes develop glandular epithelium. It's not that the squamous cells have undergone metaplasia, okay? It's just, it may be part of the reason may be that, we have rests, little embryonic rests throughout our female genital tract, and those can undergo responses to a variety of stimuli, and they can start to proliferate. And it's a very insignificant clinical finding when that occurs, usually. You just have to make sure that it's not confused with another abnormality. Now, when adenosis occurs, it most often affects the anterior vaginal wall. It can also be associated with reserve cell hyperplasia, squamous metaplasia, and microglandular hyperplasia, just like normal glandular endocervical epithelium is. When adenosis occurs in the setting of DES exposure, the mean age is 21 when it's first detected, and these patients are at risk for developing adenocarcinoma, a particular one called clear cell carcinoma that you'll learn about much later. Well, not really that much later, really. Think about it, in Module 7. So this is a colposcopic view of adenosis, and we're actually looking at vagina here, so it's kind of hard to appreciate that because you don't have an os landmark too well, although I think this right here, this is actually what we're seeing here. Do you know that the normal vaginal epithelium is very pale pink, just like the ectocervix? When you start to see a reddish color, that's actually a clue to the possible presence of glandular epithelium. And so the reddish epithelium here is actually what's helping that gynecologist focus on an area that might be adenosis. And what does it look like on histology? Well, here's an example. Again, what are we seeing here? We have some normal squamous epithelium on the surface, but it's not quite, and I'll tell you why in just a moment. But underneath in the stroma here is a group of benign appearing glandular cells. Forming a little cystic space sometimes. We don't normally see this in the vagina. It shouldn't be there. It resembles actually a sample from the transformation zone of the cervix. So when you see glandular epithelium, this by itself right here is indicative of vaginal adenosis. Now, what happens to these glandular cells is that they can undergo squamous metaplasia, just like these cervical areas do. And so this happens to be an area with overlying mature squamous metaplasia, okay? Now, some other abnormalities that can occur in the cervix, some of these are more evident on colposcopic exam by the clinician. Normally the ectocervix is primarily covered by squamous epithelium, and that's what you're going to see primarily on the ectocervix. When part of it starts, where part of the glandular epithelium kind of proceeds out onto the ectocervix, which happens, and it's not anything abnormal, it's just something worth noting. That's called ectropion, okay? And it appears red on colposcopy, looks like an erosion, just like that adenosis did in the vagina. And the red appearance is simply due to the underlying vascular component. It can regress over time. It may be more common in DES exposed women, but it's totally benign. Here's an example of one. Now again, it's not uncommon to see, you obviously right at the cervical os here, you're usually going to see a change between the ectocervix and the endocervix. But this amount of endocervical tissue on the external cervix is more than I would, more than normal, okay? So there's this whole area right here, this whole red area here actually represents endocervical tissue that's kind of everted onto the external cervix.
That's the transformation zone.
Yeah, basically, this is the transformation zone, you know what I mean? Right here where you have endocervical versus ectocervical tissue. But what happens what this tissue will undergo is oftentimes undergo metaplasia because of its exposure to the vaginal environment and the acids that are sometimes, the pH that's present within the normal vagina will be an irritant to this amount of endocervical epithelium. And so it will often undergo squamous metaplasia in response. So, and by the time that happens, then can you really tell exactly, it's not going to look red anymore, all right? But at this point, it is looking red because it's all pretty native looking endocervical epithelium and a lot of it on the cervix. All right, any questions? Oh, okay, that's nice, isn't it? Okay, that was found here, right? Here or it was found here at the school, right? Yeah. Who found it? I forget now. Anyways, if you ever see anything that looks interesting, that looks like something artistic or a symbol, share it with us, because we do like, especially Mr. Franco, he likes to collect these sort of things. All right, so any questions? All right, good. All right, so we're at 5 after 10. Let's meet back at 20 after for the next lecture, okay? Let's see. Will you help me out with this? That way we're going to run down.
I'll load it up, don't worry.
Well,